The rule hospitals use when capacity runs out. Most hospital decisions don't happen in exam rooms. They happen in the space between capacity and uncertainty. When there are enough beds, enough staff, enough room to absorb risk, medicine behaves the way people expect it to. Patients are admitted, questions are answered, care moves forward. But when that room disappears, the system doesn't stop working. It changes how it decides. Those changes aren't announced. They don't show up on signage or discharge paperwork. They happen quietly, inside thresholds most patients never see. This episode is about what happens after that line is crossed. How capacity becomes movement, how uncertainty becomes a liability, and how the cost of waiting gets shifted, piece by piece, onto people who never agreed to carry it. To understand how those decisions work, you have to start where most people first feel them, in the waiting room. Part 1. The quiet room. Most people misunderstand what a full hospital actually looks like. They imagine noise, alarms, urgency spilling into the hallway. But the waiting room isn't loud, no shouting, no chaos. No visible emergency, just people sitting the way people sit when they're trying not to look sick. Jackets still on, phones in their hands, bags tucked close to their feet. A woman shifts in her chair and checks the clock, even though she checked it less than a minute ago. Someone coughs and immediately says, "Sorry," like they've done something wrong. Nothing about the room tells you what's already happening. Time behaves differently here. Minutes stretch. You notice how often the doors open. You notice how rarely your name is called. Someone who arrived after you gets taken back. You feel a brief flash of relief for them, followed by a quieter question you don't want to answer. Why them and not me? You replay the intake questions in your head. Did I explain it clearly enough? Did I downplay something I shouldn't have? Did I say too much? Waiting isn't neutral. Waiting asks you to decide how much uncertainty you're willing to tolerate without information. You watch staff move in and out through the doors. They don't linger. Conversations happen standing up. No one looks rushed exactly, but no one looks idle either. You start doing calculations you never expected to make. How long since someone checked on me? How long before it's reasonable to ask again? At what point does patience turn into risk? From the outside, the room still looks calm. From where you're sitting, time feels heavier with every minute, because somewhere behind those doors, a decision has already been made. Not about treatment, not about diagnosis, about priority, about who can be helped right now and who can't. And if you're still sitting there, you have no way of knowing which side of that line you're on. Most of us go to hospitals with a simple assumption. If you're sick enough, you get a bed. If it's serious, someone makes space. If you need care, the system adjusts. That assumption feels humane. It feels obvious. It feels true. It isn't. Hospitals don't run on compassion alone. They run on limits. And once those limits are reached, the rules don't disappear. They change, quietly. When people hear that a hospital is out of beds, they imagine something simple, an empty frame, a mattress behind a curtain, a room waiting to be filled. But a hospital bed isn't furniture. It's a promise that care, attention, monitoring, and follow-through can all exist at the same time. That promise holds only if several conditions align: a nurse assigned and available, a physician with enough capacity to manage another case, monitoring equipment that isn't already in use, support staff to handle labs, transport, medications, imaging, and staffing ratios that cannot be crossed without triggering regulatory consequences. If even one of those pieces is missing, the promise breaks. The bed might still exist physically, it might still exist on paper, but functionally, it's gone. Imagine a medical surgical unit with 30 physical beds. On paper, that's capacity. But that unit runs on staffing ratios. 1 nurse for every 5 patients. 6 nurses are required to open all 30 beds safely. If 6 nurses show up, the unit has 30 usable beds. If 1 nurse calls out sick, the math changes immediately. Now the unit can staff 25 patients. 5 beds disappear. No disaster, no surge, no mistake, just math. Now add reality. 1 patient is medically stable but can't be discharged. They're waiting for rehab placement. That bed is locked. Another patient requires isolation. Infection control rules block the adjacent bed. Another bed disappears. A third patient begins deteriorating. Their nurse now spends far more time in one room than planned. That bed stays open, but attention is gone. By mid-shift, a unit that has 30 beds is effectively operating at 21. And this is happening simultaneously across multiple units. ICU beds feel differently than med-surg. Step-down units bottleneck patients who should move out of intensive care but can't. Specialty units depend on specific staff who can't be replaced easily. Hospitals don't move patients freely between these spaces. You can't put an ICU patient in a med-surg bed. You can't exceed staffing ratios without consequences. You can't replace specialized nurses instantly. So capacity doesn't shift. It fractures. This is why hospitals don't talk about beds. They talk about staffed capacity, and that phrase sounds abstract. Numbers, ratios, dashboards, thresholds. But capacity doesn't just determine how many people a hospital can hold. It determines how decisions move once people are already inside. Because when space tightens, the system doesn't stop functioning, it recalibrates. At first, that recalibration looks administrative. Beds close, transfers slow, admissions are screened more carefully. But very quickly it becomes personal. Once the hospital no longer has room to absorb uncertainty, uncertainty itself becomes the problem the system is trying to manage. That's when attention starts to shift, not away from sick patients, but toward patients the system understands. Clear trajectories become valuable. Predictable outcomes become stabilizing. Cases that fit established paths move forward more easily, and cases that don't begin to drift. No one announces this shift. There's no memo that says, from this point on, ambiguity costs more. It happens through small, reasonable decisions made under pressure. Another reassessment instead of an admission. Another note added instead of a plan finalized. Another hour of observation instead of a commitment. From the outside, care looks continuous. From the inside, patients are being sorted by how easily the system can carry them. This is where capacity stops being about beds and starts being about movement. Part 2. How patients are quietly sorted once capacity is tight. Once a hospital crosses the line where capacity tightens, something subtle but profound changes. The question is no longer, who needs care? It becomes, who can move? That shift doesn't happen in policy memos or public announcements. It happens in thousands of small decisions that, taken together, quietly sort patients into different futures. This sorting is not about deservingness. It's not about compassion or indifference. It's about predictability. Hospitals under strain become deeply allergic to uncertainty. Predictable patients move. Unpredictable patients stall. This is the first and most important sorting rule, and it rarely gets named. A patient whose trajectory is clear, even if they're quite ill, is easier for the system to manage than a patient whose condition sits in between known categories. A straightforward pneumonia with a standard treatment path is easier than chest pain that doesn't quite fit the algorithm. A fracture with a clear surgical plan is easier than neurological symptoms that are intermittent, vague, or evolving. Predictability creates momentum. Uncertainty creates drag. Once capacity tightens, that drag starts to matter more than acuity alone. Documentation becomes the next sorting mechanism. Medical charts are not neutral records. They are tools that shape how attention moves. When a patient's story fits cleanly into existing templates, their chart reads smoothly. When it doesn't, the chart becomes dense, qualified, cautious. Words like unclear, possibly, cannot rule out, and will continue to monitor accumulate. None of that language is wrong. In fact, it's often the most honest description of what's happening. But under strain, charts that contain ambiguity tend to slow everything around them. Every handoff compresses the story further. A long, nuanced clinical narrative becomes a problem list. The problem list becomes a summary sentence. The summary sentence becomes a label. Once that happens, concern doesn't disappear. It diffuses. No one decides to deprioritize the patient. The system simply has fewer places to put them. This is where observation status quietly expands. Observation is often misunderstood as a clinical category. In reality, it's an operational one. Observation allows hospitals to continue monitoring patients without fully committing inpatient resources. It sits between admission and discharge. Under normal conditions, it's a temporary pause while uncertainty resolves. Under strain, observation becomes a sorting tool. Patients whose outcomes are unclear are placed into observation not because it's the best clinical choice, but because it buys time without consuming scarce inpatient capacity. That time feels reasonable in the moment. Another set of labs, another imaging study, another reassessment, another shift. Each step is defensible. Each decision makes sense locally. But taken together, observation can stretch indefinitely. The longer a patient remains in observation, the more they become part of the system's background load. Background load is the set of patients who are stable enough not to demand immediate action, but not resolved enough to disappear. They occupy space without forcing decisions. Under strain, background load is dangerous, not because these patients are ignored, they aren't, but because they don't trigger escalation, they don't demand reallocation, they simply persist. Discharge friction compounds this effect. Many patients are clinically ready to leave but can't. They're waiting for rehab placement, for home health services, for durable medical equipment, for family availability, for insurance authorization. None of these delays are medical. All of them occupy beds, staff time, and attention. Under strain, discharge friction acts like glue. Beds that should turn over don't. Patients who should move forward remain stuck. New admissions have fewer places to go. This creates a second sorting layer. Patients with strong social support, clear housing, and straightforward insurance move faster. Patients without those things linger. Again, no one decides to punish vulnerability. But vulnerability slows movement, and movement is what the system needs most when capacity tightens. Social factors quietly become clinical ones. A patient with mild symptoms but no safe place to go may remain admitted longer than a patient with more serious symptoms but better support. Not because one matters more, but because the system can resolve one case cleanly and not the other. Over time, clinicians internalize this logic. They don't articulate it, they feel it. They learn which patients will go somewhere and which ones will get stuck. They learn which cases will close cleanly and which will linger across shifts. This affects decision-making in subtle ways. Admission thresholds shift. Observation stretches. Discharge planning starts earlier and earlier. Documentation becomes more conservative. Language changes. Concerning becomes stable. Needs monitoring becomes no acute change. Unclear etiology becomes likely non-emergent. None of these phrases are false. But together, they soften urgency. Shift change accelerates this process. Every handoff compresses complexity. New clinicians inherit summaries rather than full stories. Nuance flattens. What once felt unresolved now feels familiar. This isn't negligence. It's how humans manage cognitive load. Under normal conditions, the system has enough slack to re-expand nuance. Under strain, it doesn't. So uncertainty becomes normalized. Timing begins to matter in ways patients rarely realize. Arrive during the day, and there are more staff, more diagnostics, more specialists available. Ambiguity resolves faster. Arrive at night, and the system runs leaner by design. Fewer consultants on site. Longer waits for imaging. More reliance on judgment rather than protocol. Under strain, that difference becomes decisive. A patient who arrives at noon with ambiguous symptoms may receive an admission and a full workup. The same patient arriving at midnight may be observed, reassessed, and discharged with follow-up instructions. Not because the illness changed, because the system did. None of this feels like triage in the traditional sense. No one is being ranked in a line. No one is being denied care outright. Instead, patients are being sorted by how easily the system can carry them. Predictable cases move forward. Unpredictable cases slow down. Complex cases with social friction linger. This sorting is invisible to patients. From their perspective, care continues. Nurses check in. Vital signs are taken. Orders are followed. What they feel instead is a loss of momentum. Time stretches. Urgency fades. The sense that something is supposed to happen dissolves. They become safe enough to wait. This is not a failure of compassion. It's a system protecting itself from collapse. But protection has a cost. Every patient absorbed into background load reduces the system's ability to respond to the next arrival. Every delayed resolution shifts risk somewhere else. This is not where harm explodes, this is where it accumulates. And that accumulation doesn't stay inside the hospital, it moves downstream. By the time patients are sorted this way, nothing feels dramatic. Care hasn't stopped. Decisions are still being made. The system still looks like it's working. Sorting doesn't feel like harm in the moment. It feels like caution. It feels like waiting. It feels like buying time. But time isn't neutral. Every delay shifts risk somewhere else. Every unresolved case leans on a future decision that hasn't been made yet. Every patient held in place quietly redistributes pressure across the rest of the system. The hospital absorbs some of that strain. Staff absorb some of it. Other patients absorb some of it. And the rest moves downstream, out of the waiting room, out of the unit, out of the hospital entirely. The cost doesn't arrive all at once, and it doesn't arrive where the original decision was made. It shows up later, in different places, in ways that don't trace cleanly back to capacity or sorting or policy. This is where timing starts to matter more than diagnosis, where geography becomes a risk factor, where stable enough to wait quietly turns into delayed harm. To see that cost clearly, you have to follow it past the moment of decision. You have to watch where the waiting goes. Part 3, where the cost of waiting actually lands. The effects of waiting don't announce themselves. They don't arrive as a single moment where something clearly goes wrong. They arrive gradually, through timing, through context, through the quiet accumulation of delay. By the time the consequences are visible, they often feel disconnected from the decisions that caused them. That's what makes them easy to misunderstand. The first place the cost lands is timing. Not in minutes or hours, but in when a patient enters the system. The same symptoms can produce radically different outcomes depending on the hour of arrival, the day of the week, or the season of demand. A patient who arrives at noon enters a system at its most resourced. More staff are present. Diagnostics run faster. Specialists are more available. Escalation pathways are open. A patient who arrives at midnight enters a different system entirely. Night shifts are lean by design. There are fewer clinicians on site. Imaging may be available, but slower. Consults are often deferred unless something is clearly emergent. Decision-making relies more heavily on judgment than protocol. Under normal conditions, this works. Under strain, it compounds. Ambiguity that might resolve quickly during the day stretches overnight. Observation lengthens. Decisions are deferred. Let's see how this looks in the morning, becomes the default posture. Morning, in that sentence, carries a lot of weight, because by morning, the system may be facing new pressures. New admissions arrive. New priorities emerge. What was unresolved overnight becomes part of the background load the day team inherits. Timing doesn't just shape speed, it shapes outcomes. The next place the cost lands is geography. Urban hospitals often have options. If one facility is overwhelmed, another may be nearby. Transfers can stall temporarily, waiting for capacity to open elsewhere. Rural hospitals don't have that luxury. When a rural hospital reaches its limits, there may be nowhere to send patients. Specialty care is hours away. Transport depends on weather, staffing, and availability. Receiving hospitals may already be strained themselves, so patients stay. Longer than planned, longer than comfortable. Clinicians manage conditions they know would be better served elsewhere. They monitor carefully. They compensate. They stretch. Care continues, but risk increases. This isn't because rural clinicians are less capable, it's because the system around them has fewer buffers. Geography determines how much delay a patient can survive. The cost also lands unevenly across types of patients. Those with clear diagnoses and standard treatment paths tend to move through strained systems more cleanly. Their needs are easier to anticipate. Their trajectories are easier to plan around. Patients with chronic illness, complex medical histories, or overlapping symptoms carry more uncertainty. Their care requires time, coordination, and flexibility. When the system is tight, flexibility disappears first. These patients don't experience dramatic denial of care. They experience erosion. Symptoms persist. Pain is managed, but not resolved. Questions remain unanswered longer than they should. Follow-up plans become less specific. Each individual choice is reasonable. Together, they create delayed harm. Delayed harm is difficult to measure. It doesn't show up as a clear adverse event. It appears as deterioration that could have been prevented, as complications that emerge later, as hospitalizations that happen days or weeks after discharge. Because the delay didn't feel dangerous at the time, it rarely gets labeled as causal. But the patient feels it. They sense that something was missed, or postponed, or never quite finished. The cost also lands on staff. Clinicians carry the weight of unresolved decisions long after shifts end. A nurse knows which patients were stretched thin that night. A physician remembers the cases that didn't quite sit right. An administrator sees the numbers and understands what they represent. Inside hospitals, there's language for this. Moral residue, the emotional and cognitive weight that remains after doing the best possible thing in a constrained situation. It's the residue left when no option is clearly right, but a choice still has to be made. Moral residue doesn't require dramatic failure. It accumulates through routine compromises. Each delayed admission, each extended observation, each transfer that doesn't happen, each patient who is stable enough to wait. Over time, this residue changes behavior. Clinicians adapt their expectations. They lower thresholds for what feels acceptable. They normalize conditions that once felt temporary. This is how strain becomes standard. Normalization doesn't feel like giving up. It feels like professionalism. It feels like learning how to function in reality. But normalization has consequences. When crisis posture becomes baseline posture, the system loses its ability to recognize when it's operating outside safe margins. What once triggered alarm now feels familiar. Delayed care stops feeling delayed. It feels normal. This makes future harm harder to detect and easier to dismiss. The cost also lands outside the hospital. Patients discharged under strain carry unresolved issues into the community. Follow-up appointments may be delayed. Primary care systems absorb complexity they aren't resourced to handle. Families become caregivers without preparation. Symptoms that should have been stabilized in the hospital become home management problems. The system has shifted the burden downstream, from inpatient units to outpatient clinics, from clinicians to families, from institutions to individuals. Again, no one decides to do this explicitly. It emerges from pressure. And because the burden shifts gradually, it's difficult to trace responsibility. This is why these systems feel both functional and fragile at the same time. They continue to operate. Patients are seen. Care is delivered. But the margin for error shrinks. The cost of waiting accumulates in places that don't trigger alarms, in timing differences, in geographic isolation, in chronic illness, in staff burnout, in delayed recovery. By the time outcomes diverge, the cause is already buried under layers of reasonable decisions. This is what makes these systems dangerous to misunderstand. From the outside, it can look like nothing went wrong. From the inside, everyone knows how close it came. And over time, that closeness becomes familiar. The system doesn't collapse, it adapts. But adaptation has a price, and that price is rarely paid all at once. It's paid in pieces, by people who never see the full picture. Part 4. When the system is still working. Most people never experience a hospital in crisis. They experience a hospital operating at its limits. Care continues. Decisions are made. The system holds together. But once capacity tightens, another set of rules quietly takes over. Rules that decide who moves forward and who waits, who absorbs uncertainty and who is protected from it, who carries risk now and who carries it later. These rules aren't written down in one place, they aren't announced, and they aren't made all at once. They emerge from pressure, and by the time they feel personal, they've already shaped the outcome. Understanding this doesn't make the system cruel, it makes it visible. Subscribe for long-form stories about how systems actually work when they're under pressure. Each episode looks at a moment where limits are reached, decisions are made quietly, and the consequences unfold over time.